Good evening, sir.
Good evening, Anjana. Good evening.
Good evening, sir.
Good evening, sir. Good evening. Good evening. We'll start in 1 minute's time, okay? I think we'll start. Yeah, Asmita, shall I start? Asmita? Asmita, are you there? Asmita?
Yes.
Yeah. Okay, I'll start, no? Okay, right.
Yeah, you can.
Okay, thank you, thank you, thank you. So good evening to all of you. I think this is the 167th session. As usual, I will start with a very short case first. Then I'll go to the proper case. Okay. Is my screen seen?
Yes, sir. Yes, sir. Yes, sir.
Okay, okay, right. Now, this is an ultra short case. This elderly man, in fact, came with an unrelated complaint. He did not come for this complaint. This is the finding. Look very carefully. Looking to the left side, looking to the right, looking up. Looking down. The left again. Looking down and to the left. Looking up and to the left. Up and to the right. And convergence. Rest of the findings are normal. I will show the video once again. Looking to the left side. Right. Again left. Right. Up. Then down. Straight down. Down and to the right. Down and to the left. Up, left up and out. Right up and down. Okay, any thoughts? What did you observe in this? Yeah, pardon?
Left 6, sir.
Okay. So I didn't hear you. Left?
Left 6th nerve palsy, sir.
Okay, very good. Is there anything else other than the left sixth nerve palsy? What happens when looking to the right side? Let me show that video once again. See what happened to the right side. Left eye fails to adduct also, no? What you said is correct. It's got abduction failed on the left side. There is also an adduction failure on the left. Okay. Then look again. Sorry. So what do you think now? Okay, what do you think now? What will you advise this patient? He's got abduction failure on the left side. partial adduction failure on the left, again on the left side.
So duction we have to do, sir.
Duction also same. No change in the duction. Same restriction is same.
Close one eye and observe the movement, sir.
Yeah, that did not show the video, but there is again the same restriction is seen. It is not a concomitant skin. It's got a real restriction.
New segment, sir.
Pardon? You want to
New
see the
segment
video?
test, sir.
Okay, you think it's going to be myasthenia, very well, but he had been having this, he has no complaint regarding the eye at all. He come for something else, some peripheral neuropathy or something like that. When I started examining, I found this finding, then I asked him, then he said, this has been there from the very beginning. From early childhood, he has been having this problem. Somebody has told him he has got a skin and he's not bothered about it. Okay, I'll give you a clue. What happened to the palpebral fissure on the right eye compared to the left eye?
Decrease.
It's decreased on adduction, no? On the left side is widened. So which condition produced that thing?
Duane, sir.
Pardon? There's a Duane's retraction syndrome.
Duane's.
Yeah, Duane's retraction syndrome. See here, this is called the type 2 Duane's retraction. Classical Duane's is only one eye failure of abduction, nothing else. On abducting eye will show the widened palpebral fissure, adducting eye will show the palpebral fissure will become narrow. The type 2 is that the same eye, there is abduction as well as adduction failure, as in our patient. Type 3 means it is bilateral. It present on both eyes. There are 3 types of Duane's retraction syndrome. The other clue to is that I'll show you one more finding. When he looks up, the eyes diverge. There is also another phenomena usually come across in Duane's retraction syndrome. Either it is called a V pattern and diverge. V pattern means it's like a V. On looking down, the eyes will come closer. On looking up, the eyes diverge. Or the other way around, inverted V, where the eyes will, when it comes down, it diverges. On looking up, it converges. So look very carefully now. On looking up, what happens to the eye? See that thing? On looking up, the eye goes into divergence. There is also another phenomena which you see in persons with the Duane's retraction syndrome. This is because aberrant reinnervation of the extraocular muscles. Otherwise, the right eye, there is no reason why the eye should go out. Okay. And that after some time it will come. That's the thing. Yes. Rest of the findings same. So this is only short case. Duane's retraction syndrome. This is what this is on looking up and looking down. Looking up, the eyes diverge. Looking down, the eyes converge, or little normal position. This
What
will
is there in type 1, sir? Type 1.
Type 1 is only abduction failure.
Okay, sir.
No adduction failure, but the palpebral may narrow on adduction and the palpebral widen on abduction. Type 2, the same eye, there is abduction as well as adduction failure, just like our patient. This patient's mild adduction failure looking to the right side, on the left eye. Okay. The same patient, adduction failure is they can see make on adduction. Okay. So I'll skip that, go to the next problem. So shall I go to the next story?
Yes, sir.
Okay. So this is a 50-year-old man. He's an army personnel. He came for leave from the army. He noticed loosening of his suppress from his left foot for the last 8 months. And also noticed episodic inversion of the left foot while walking for the last 4 months. Yes, this is the only 2 complaints by which he came to me. No sensory complaints, no root pain. History low backache for the last 1 year, but that is a leading question. He did not volunteer there. He said he has been there for low backache for 3-4 years, but it's no root pain characteristic is not present. These are the only 2 complaints. Loosening of the chappers in left foot for 8 months and inversion of the left foot while walking for the last 4 months. So let's see the findings now. Don't power all normal in the upper limb. All muscles were normal. There is no incoordination in the upper limb. The tone is slightly appears faster on the left side compared to the right. It's on the left side. Then the hip flexion, knee extension were normal. There is weakness in the left dorsiflexion. The right side it was normal. EHL was normal on the right side, weak on the left side. Plantar flexion was normal. Flexor pollicis longus also normal bilaterally. Inversion was normal on the right side. Cori weak, not very sure, mild cori weakness on the right side, left side. Inversion was normal on the right side, dorsally weak on the right side, left side. Abduction was normal. Lying on the right side also and left side also is normal abduction on the right, normal abduction on the left side, normal power. The reflexes were normally elicited in the upper limb. Some suspicion of a decreased jack, but not otherwise normal. Finger flexion normal or absent. Abdominal press intact. Knee jacks is brisk bilaterally or almost normal and not called brisk, well elicitable. Right angle jack is well elicitable. Left angle was absent. There is a affected limb that was absent. Plantar was however upgoing bilaterally, more definitely upgoing on the left side. Not undoubtedly upgoing. Sensations were all normal. Able to feel normally. Joint pulse is also normal. This is the gait of the patient. Prop on the left side. Step page gait. Homburg's negative. So this is the finding. So motor system upper limbs tone power normal. The lower limb no wasting seen. Tone cori miles faster the left lower limb on lifting up in the bed. Weakness of left dorsiflexus, EHL and evertus put 1 to 2 power only. Mild weakness of cori mild weakness of invasion, almost normal. DTR, both upper limbs all normal, finger flexion not elicited. Both lower limb, both knee jacks were normal. Right angle jack normal, left angle jack was absent. Abdominal reflex bilaterally normal, plantar both upgoing. More definitely upgoing on the left side, right again, slightly upgoing, not definitely downgoing. Sensory system all normal, Romberg's negative, step page gait on the left, SLR negative. So where is the localization? If you want the findings once again, I can tell.
left plantar flexion is normal, sir.
Plantar flexion is normal bilaterally. Flexor hallucis longus also is normal. Inversion is mildly weak on the left side, but marked weakness eversion, dorsiflexion, and EHL on the left side. Hip abduction normal.
It's a predominant lower motor syndrome, sir.
Correct.
And a pure motor weakness with predominant lower motor symptoms with doubtful human signs at the in the form of spasticity
And upgoing plantar.
and upgoing plantar. So localizing it can be at the, if you consider only pure motor, lower motor, then peripheral nerve, or it can be myeloradiculopathy. Sir.
Correct. Perfect. Very good. Okay. So that is one possibility, myeloradiculopathy. Is there anyone else like to make any comment about this case?
Bilateral corticospinal tract and anterior horn.
Yeah. So what else will you consider?
ALS.
ALS, okay. But only weakness is confined in the distribution of that particular nerve or root. Now, that like dorsiflexion inversion and this thing, okay. That's a possibility. Okay. So that's your localized. Anyone else want to make any other possible? So let us analyze the problem. Is it purely human? Obviously not. So it's got a human plus element. That's the first statement. Now let us localize two things. It's got element finding. Let us localize the element finding. It's got a human finding. Let us localize the human finding. So first, where do you localize the foot drop? Element finding. Is it left sciatic nerve palsy versus left L5SM radiculopathy? Now, what is against L5SM radiculopathy? We thought myeloradiculopathy is one possibility. Is there anything against L5SM radiculopathy?
Hip extension.
Hip abduction.
Okay, that we expect a hip abduction to be weak. That's a good point. But sometimes you can predominate maybe distal. Okay, that's a good point. That's a hip abductors are normal. That's against. But anyway, that can be totally ruled out because that's a strong muscle hip abduction. The other is not that strong, so it may be predominantly weakness. But your point is well taken. We are not sure.
No radicular pain.
No radicular pain.
No sensory findings.
No sense.
Plantar flexion is normal.
Right, but absent angle check is there. No, all seen a radiculopathy, all may not be affected equally. If it is a component only, you don't get an absent angle. But angle check is absent. So there is S1 involvement is there. So muscle supplied all may not be affected all the time. Mild inversion weakness also is there. So we are not very sure. Okay, one possibility is self-ascent. There are many points against, as you said. The sensory is not there. There is no root pain. That may not be there all the time. And he has got a most important point is hip abduction is normal. Agreed. Then what is against sciatic neuropathy? In sciatic neuropathy, hip abduction may be normal.
The plantar flexion and
Plantar flexion is not affected.
No, that's another point. Remember that in sciatic neuropathy, the sole affection may be the distribution of compound nerve. That is the most vulnerable component. The only evidence may be an absent angle check. It is not, whenever you get a lesion, don't think as if it is cut with a knife. So even if suppose got a sciatic nerve damage in the gluteal region, some injection, it may be the bund of or maximum affection may be in the distribution of the compound nerve. Because that is the most vulnerable part of the sciatic nerve. So you have to think, is it possible? It's possible. But the strong point again is there's a sensory affection. Usually, sensory affection is more likely to be affected in nerve rather than root. Why is it so? In radiculopathy, you may not have sensory involvement at all. Why?
Many dermatomes are
Overlap because of the overlap.
Not because even sensory symptoms may not be there in science again. Overlap is only for the science. The reason is that the roots are separate. See, the motor roots and the sensory roots are separate in the chordaeque nerve. They join to form only the spinal nerve and the outside intervertebral foramina. Suppose the motor roots alone are affected inside the spinal canal, you won't have any sensory involvement. Unlike a nerve, in the nerve, it is a mixed nerve. So its sensory loss is more likely to be there in nerve involvement rather than root involvement. Putting it in other words, all root involvement need not have a sensory involvement. Depends upon whether your motor root is affected or not. But that is unlikely for a theoretically possible, because in certain specific conditions like multifocal motor neuropathy, where that's only selectively is affected. That's possible. So, but more likely for a root than a nerve. So there's a sensory effect. That's again. It can be anticondylar disease, as Bruce was telling. Possible. Only confined there, but only thing is anticondylar only producing slightly weakness in the left foot. Slightly odd, no?
Yeah.
But possible. It's still possible. Okay.
I have one doubt, sir.
Yeah, please.
Sir, this patient has the plantar flexion is normal, but the ankle is absent. That favors root versus nerve, sir. It favors which sciatic root
No,
or
that-
it should be nerve.
No, that you can't differentiate, because the reflex loss is an early one, maybe the early finding in a radiculopathy, even early finding in nerve involvement also. Because the reflex is the one which requires the fastest conduction, no? That may be the first lost in any radiculopathy or even sometimes in a nerve involvement, before the motor part gets affected or the sensory part gets affected.
Okay.
Okay. Now, where is the site of localized pyramidal lesion? Is it in the pyramidal tract? Maybe anywhere, I don't know. Maybe anywhere above L2. Maybe in the spinal cord, the dorsal cord, maybe in the cervical cord, or in the brain itself. We don't know where it is. At the moment, we are ignorant. Because he has no complaint pertaining to whether it has been there earlier also, we don't know. Whether it's got unclated cervical spondylotic myelopathy also, we don't know. So that's, we do not know. So that without investigation, we can't say. Maybe in the cord, maybe in the hemisphere. So what investigation do you need now?
NCS.
Nerve conduction and MRI.
Yes.
Okay. Very good. Let us see the nerve conduction. This is a nerve conduction which the patient has brought with him. There is no potential picked up from the left peroneal EDB. From the tibialis anterior, from the tibial nerve also, the amplitude is low. So that means the tibial component is also affected, even though clinically you couldn't make it out. Now, from the peroneal, the proximal pickup is also affected. That is, it is not only confined to EDB, it's also the tibialis anterior also is weak. That is, the lesion is proximal. Okay, then coming to the sensory, this is not sensory, this is motor conduction. Upper limb is normal. Now coming to the sensory, in one value, the left sural was decreased compared to the right. One is 11, the other is 6. When the second time it was done, it was not there, not much of a gross difference. So probably sensory is not affected. They say some decrease is there, but still not significant. More than 50% decrease is not there. So sensory for all practical purposes is not affected in our patient. FA, as suspected, did not get it from the left peroneal because severe loss of amplitude to the CMAP on the left side. Now, how does the nerve conduction help you in localization?
Radiculopathy, sir. Snaps are preserved.
Very good. Snaps are preserved. So it's a long-standing problem. So most likely it's a radiculopathy. Right. So what investigation you need now? MRI. So MRI was done. This is the MRI of the sagittal cut of the lumbar area. But a disc between L4 and L5 is one. Axial cut I will show you one by one. Above downwards. It's all normal. Now, see, it's got a disc on that side, on the right side. That is L4, L5 level. Then L4, L5 is one level bilateral, more on the left side. This is the compression on the left side. So I will do the static one. So this is disc on the right side, compress the neural foramen on the right side. In the lower level, it is bilateral, more on the foraminal stenosis on the left side. Now, what is the diagnosis?
The cervical was done, sir.
Okay, very good. So now this is, so the element part may be radiculopathy. Now we have to explain why the sciatic lesion, the pyramidal tract lesion. So we want a cervical spine also. We want MRI brain as well as upper cervical score. First upper cervical score, upper part of spinal cord above the dorsal. This is cervical spine. Normal. Dorsal dorsal is normal. This is a lumbar. In fact, patients are only brought with the sagittal cut. Axial cut of the cervical and dorsal cord is not available. So brain was also not done, but only some part of the brain could be seen in the initial pictures. Otherwise, no proper brain cut is not taken. Now, what do you want to do now?
Brain and axial cervical spine.
Okay, cervical spine axial. Okay, it was not done. You can do that, but the axial sagittal cut is normal. You can do, should have done that. Okay. Probably it must have done the previous place where it was done. Probably the film is not with the patient. Presuming it is normal, then what will you do? Will you do unrelated old spondylotic myelopathy? Present one is radiculopathy. Shall we operate on the patient or do something else?
EMG.
EMG,
Very
sir.
good. Why EMG for? You're right. Pure motor, no? No sensory finding, pure motor. So what else you need? So exam is done. If you want to look at the tongue, you can say fibrillations in the tongue. You got fibrillations in the tongue. Usually this should be in the resting position. I could make it. That movements were normal. But put it there is turbulence movement in the tongue. On the floor of the mouth, now you can make out. You may not be able to see that there is fibrillations in the tongue. So what will you like to do now?
Needles.
EMG.
EMG. So let us see the EMG finding now. This is from the left corticeps. No spontaneous activity. What do you find there in this EMG?
A large amplitude potential, sir.
More than that, the recruitment ratio is increased. That, see, the firing frequency of the first potential, when the second potential appears, is called the firing frequency. See, the first potential is firing at a faster rate. Even when the second potential comes, it is firing at a faster rate. That is as given increased recruitment ratio. That means the motor unit is firing at a faster rate before the second motor unit got recruited. That is an early evidence of a denervation.
Sir, can you repeat, sir? I'm saying, sir.
Now, if you would, in fact, either when it is for us, I will take another class. I will tell you how to. I think many people, when you look at the denervation, you just look at the amplitude and the indication difference. But that is not the earliest evidence. Here you find there is no spontaneous activity at all. So normally what happens means that when you do the muscle contraction, first the small MEP will start firing. Okay. And when it becomes, the firing rate gradually increases when you increase the power. When the rate becomes more than 5, the second potential get recruited. Little more larger potential will come. Then when that firing, then the first frequency will also be increasing the firing rate. So in the after that second portal also increases more than 5 hertz, the third portal will get recruited. That is called the size principle. For the small size potential motor unit, the next one and next one get recruited. See, the power is generated by two things. One, not only by the size of the potential, but also the firing rate of the potential. More firing rate, the more power is generated. The size of the motor, more number of motor fibers involved, the size of the potential also will power is generated. So in such patient, the number of motor units is less as a denervation. The first fellow has to work more. The first motor unit has to fire at a faster frequency to generate that much amount of power before the second one gets recruited, because the sufficient number of motor units are not there. So the ratio or the firing frequency of the first potential when the second one start appearing is called the recruitment ratio. So that is increased in early motor neuron, early denervation, because motor unit is not there, so it has to fire more. That is the recruitment ratio. In fact, if you want, I can in a simplified way, I can elaborate with examples in the next class. If you want, I can do that. Okay,
Yes.
that's what this.
Yes,
Shall I
yes.
do? Okay, next I'll do and I'll some picture. I'll copy some examples also, and the graphic representation also. I'll copy it and next time do that. It will take some time. That is why I did not do it now. I'm not tell it now. So I'll take next week.
Okay, sir.
So let us this one. That's I said because very important, because otherwise you miss an early denervation like this patient. Now I'm going the interference is almost normal. Okay. Now let's check the left TA, tibialis. Can find fibrillations. Basically, the regular one is fibrillation. Tuck is fibrillation. That's fibrillation. You can find the positive This all spontaneous activity is extreme profuse fibrillation of the tibialis anterior. Decrease interference. Then coming to the right tibialis anterior, there is fasciculation that we see. That is normal. So in fact, only in the right tibialis and only fibrillation is there. No motor movement potential is normal. The size of the recruitment is also, normal, and the interference is also normal. But is that enough for you to call motor neuron disease? No, you also can put in innervation in the lower limb. It's got displaced bilaterally. So what will you like to do?
Tongue EMG, sir.
Tongue EMG, you can. Already we got fibrillations, okay. From the other limb also, upper limb also you have to do, no? So that means we got 3 segments. So this is from the FDA you have done the upper limb. Secretions. And large potential. Normal size potential is normal. So you could find an active denervation even from the upper limb muscles. And there's a tongue fibrillation, which I didn't know the tongue because already seen there. And we have documented 3 segments involvement with the element finding along with pyramid. So what is the diagnosis now? Motor neuron disease. So the idea of bringing the case is that sometimes they can initial phase very difficult. Suppose the tongue is not involved in this patient. In fact, I hit one history from me. Subsequently gave history some dysarthria on leading question. He said some dysarthria was noticed by the wife. But that was not the first complaint in this. He came to you only with the lower limb weakness. So when you come, then we tend to think of only, we do not examine the K nerve also. That's usual situation in the OPD. Come with a foot drop, we examine only the foot drop and upper limb maximum. Since there's no complete upper limb, we don't accept complete examination. But when you get no sensory involvement, only pure motor involvement, always keep the back of the mind, all three localization, root, nerve, plus anterior nerves. And you have to look for other areas involvement. So that's the story of this patient. Any questions?
Patient has got a lumbar canal stenosis. There is an angle jerk is also absent, sir.
Correct. Angle jerk is also absent. That's also another good point. It's got a good power.
Yeah.
See, plantar flexion is good. Still angle jerk is absent. So naturally, we will think away from motor neuron disease.
Yeah.
Unless the element weakness is profound, we don't expect angle jerk to be lost in anterior consequences. And that's also the trick in this patient.
Yes, sir.
Sir,
He has.
there were no upper motor neuron signs, no, sir, in this patient.
Yeah, he
Because
had upgoing plantar. Upgoing plantar was there. If upgoing plantar was not there and then some spasticity, we wouldn't have bothered. I would have even thought of motor neuron. You would think only pure element finding. Either nerve or that's why we have to think about it. Again, it could be a motor neuron, but that point we can't make a diagnosis. With only element finding in the limb, we cannot make a diagnosis of motor neuron disease. You have to follow up the patient. Then the DD will come, multifocal motor
How can we
axonopathy. Please.
Sir, how can we explain upgoing plantar on the left side, sir?
Because he has got bipyramidal signs also. Because that's pyramidal tract is also degenerated. But that's the only evidence is upgoing plantar. And mild spasticity of the left lobe. Okay. Because as you said correctly, ejects are absent or almost normal. Angle is also normal. We can't say brisk that thing. And the spasticity cannot be easily measured because already because of the element foot drop there. And that element is due to anterior constant loss. The only evidence is upgoing plantar, no other evidence of a pyramidal lesion.
Okay, sir.
Okay. Shall I go to the next case? No further questions?
Yes, sir.
Yes, sir.
Okay. This is almost similar case, little different. This 60-year-old man noticed numbness of both hands for the last 3 weeks. Tightening sensation around the abdomen for 2 weeks. Difficulty in lifting at the right foot for the last 1 month. Okay. This is a story. Numbness of both hands for 3 weeks. Tightening sensation around the abdomen for 2 weeks. And difficulty in lifting at the right foot the last 1 month. See, by the time you've had an idea about the localization is still, I haven't until the finding. Look at the findings very carefully. Cranials are all normal.
മോളുടെ കീഴെ പല്ലിക്കാട്ടിൻ്റെ ഈ കണ്ണും മുറുക്കി അപ്പിടിത്താം അപ്പോൾ അത് പറയുക ആ ചെല്ലുങ്ക ആ നാക്ക് നീട്ടുங்க
Everything is normal. Neck movement is normal.
பார்க்கட்டும் சரி லூஸாக போடணும்
He has no wasting seen. But he got spasticity of both upper limbs. There's a spasticity there. It is there bilaterally more on the right side. You make a quick movement if you got spasticity. It should be very quick supination movement. Power was normal in the upper limb. Or the small muscles were normal. No incontinence. Lower limb tone, right limb is normal. Left is also normal. Not much spasticity.
அப்படிதான் வெரி குட் அதே மாதிரியே போக்குங்க
Power normal.
சவுட்டு நூறுக்கு அப்படி முன்னாடி விடுவாங்க அப்படி
Exercise is normal.
இது செய் இந்த கையில் செய்யுங்க போதும்
Normal.
வெரி குட்
Hip abduction normal.
அப்படியே பிடிச்சி
Adduction normal.
கீழே தள்ளுங்க
Hip extension normal.
போதும் இது தள்ளி பிடிங்க போதும் இந்த பால் எப்படி இருக்கு
Dorsal of the ankle was normal in the left side, but right side it was weak. That is weak. That is complaint also. Loosening of the chapters from the right foot. AHL also weak on the right side.
அப்படி சவுட்டு பிடிங்க
Plantar function normal on the left side.
இது சவுட்டு
Again normal on the right side.
சவுட்டி பிடிக்கணும் போதும் இப்படியே இருக்கு
Invasion normal on the left side. Normal also on the right side.
கரெக்ட் முடிஞ்சிருக்காது
Invasion weak on the right side.
சரி போதும்
Upper limb produces a brisk.
cervical myelopathy.
Finger position is also well inserted. Knee jerk bilaterally brisk. But right angle was decreased.
Loose.
It's there, but
Loose
insertable, but not brisk as the knee jerk. But knee jerk is so brisk, but angle is less. Not less, normally seen. But left angle is well brisk.
நீங்க சும்மா போட்டா போதும்
It is brisk. Weaknesses on the right side. Abdominal reflex intact.
கால்
Plantar
வலிக்காதீங்க
is upgoing.
சும்மா போடுங்க வலிக்காதீங்க ப்ளீஸ்
Not
சும்மா
upgoing,
இருந்தா
not
போதும்
very indefinite on the right side, but left is upgoing. Undoubtedly upgoing.
வலிக்காது வீடு வீடுங்க எஸ் எஸ்
Touch is normal.
எஸ் எஸ் ஓகே அப்படி சொல்லணும் ஓகே
Is able to feel pain
நார்மல்
normally, except for the distal part.
இந்த குத்துதும் இதும் ஈக்குவல் தானா இல்ல வித்தியாசமா
Decrease on the distal part.
இதும் தம்முலையா ஓகே ஓகே போதும்
Decrease on the right lower.
தெரியுதில்ல வைப்ரேஷன் தெரியுதில்ல அந்த வைப்ரேஷன் இருக்குல்ல
It is decreased. Is not able to feel the vibration right thumb. Left thumb is able to feel. Able to feel the index.
அது இப்போ இல்ல
No.
இல்ல
No.
இப்போ
No. Little finger again. No.
எஸ்
Ring finger. Yes.
எஸ்
Knee. Both feet it is decreased.
எஸ்
He feels on the ankle.
எஸ் எஸ்
Feels in the ankle.
பாருங்க பாருங்க இப்போ
Absent on the iliac crest.
இல்லாட்டி இல்லைன்னு சொல்லுங்க இல்ல இல்ல
Not able to feel.
இப்போ நோ
No.
தெரியல
Is not able to feel the
இப்போ
joint sense in the right hand.
ஸ்ட்ரைட்டா இருக்கு இப்போ ஸ்ட்ரைட்டா இருக்கு இந்த மெட்டல்
Even is absent on the little finger also.
எப்படி ஸ்ட்ரைட்டா இருக்கு தெரியல
Not able to feel. He said no.
bend
He said correctly in the thumb on the left side.
bend is consistent very consistent இந்த கை எப்படி சரியா
Impaired on the little finger.
ஸ்ட்ரைட்டா இருக்கு
Impaired at both toes.
சரியா ஸ்ட்ரைட்
Then rhombox is positive. It seems to have some spasticity on the right. I don't know. It's got right foot goes in inversion. Some spastic gait is there. It's some put more effort on the right lower. So these are the findings. So no wasting of any muscles. Don't mild spasticity of both upper limbs. Spasticity right lower limb while walking, not present on the bedside examination. Power upper limb all normal, lower limb normal power of both lower limbs, except for weakness of the right dorsal plexus of the ankle, EHL and inverters of the ankle. The other hip abductors is normal. TTR, upper limb all brisk, right finger flexion not elicited, left is elicited. Lower limb knee jerk brisk bilaterally, right angle is decreased compared to the left. Left is normal or slightly brisk. Abdominal reflex is decreased on the left side. Right side it is present. Right plantar is indefinite, left is outgoing. Touch pain normal in the upper and lower limb except for distal pain loss over both feet. Vibration in the upper limb impaired in all the fingers of the right hand, impaired only in the left little finger, normal in all other fingers. And his findings are consistent. Every time it is very correct. It's not confusing with that finding. Lower limb impaired over both anti-superior leg spine and over the toes, normally felt over the knees. GPS sensation impaired in all the fingers of the right hand, just like vibration. But on the left hand, it was impaired only in the left finger, just like a vibration. Impaired over both toes. Rhombus positive, mild dragging of the right leg compared to the left. Compared to the left. So this is log. Any clarification on the findings?
Is he a diabetic, sir?
He is not a diabetic. You want the findings once again?
Yes, sir.
Okay. The video, if you want to show, I can video. Other only the findings is enough. Okay. The video and the only thing is the weakness is only in the right foot. DTR upper limbs brisk, lower limb knee jerk are brisk, right angle is decreased. The leg whichever where the weakness is there. Plantar right indefinite, left is definitely upgoing. Sensory has got impaired vibration joints in all the fingers of the right hand. The left hand, except the little finger, all other things normal, only affecting the little finger. The lower limb, both toes are affected. Anti-superior legs also easily cannot feel that thing. That's the finding. Convex is positive and gait mild dragging on the right lower limb.
Sir, abdominal reflex.
He decreased on the, in fact, very little on the right side, decreased on the left side.
So Georgia, sir.
Georgia, I did not do.
Cervical myelopathy, sir, about 356, sir.
Very good. Cervical myelopathy above C5, C6, above C5, because biceps also is brisk. Okay, that's a good thought. Anything else? Okay, that's the first thing you have to keep in mind. Cervical myelopathy. Yeah, please.
Subacute combined degeneration. Posterior column.
Okay, very good. But what's the peculiarity of this posterior column loss? See, it's affected. See, in the upper limb, it is involving only the left little finger. The other fingers are spared. Will it occur with a subacute combined degeneration? I'll come to that point later on. Okay. Okay, subacute combined degeneration is a possibility you can keep because it's got a pyramidal, but grossly asymmetrical weakness only of the right foot, not on the other limbs. Okay, anyone else would like to make a comment about this localization?
Some element findings in the lower part also.
Oh, but element finding where? That.
In The distal right lower limb.
Correct. Why can't you to say he's got a pyramidal lesion dragging on the right side?
It's 2 weeks for
Bilateral.
a pyramidal. It's 2
Pardon?
weeks for a
Pardon?
pyramidal. 2
Pardon?
weeks for
Ankle
a
check, sir.
2 weeks for a pyramidal. Sir. It's 2 weeks.
Correct. 2 week. But that side is even sensory also more affected on the right side. If you look at the right hand upper limb, the sensory lost more, all the fingers on the right upper limb. And that side is pyramidal. Maybe that means posterior column is also on the right side.
Hip
But the
flexion,
pyramidal may
hip flexion
pardon?
and knee flexion are preserved. Hip
Preserved.
flexion, knee flexion are preserved. Only the distal thing is. And
Yeah,
that is
distal weakness is not very, the problem is it's not a very severe weakness. See, it's about 3 plus to 4. So in a pyramidal weakness, the breast group of muscles affected are the dorsiflexion inversion and hip flexion. But maybe predominantly some things, for example, distal may be predominantly more affected than the proximal. That's not a strong point against. Possible.
Angle jerk
But
is produced on the left side. No, sir?
where is on the right side?
On the right side.
That's the point. In a pyramidal lesion with weak limb, you expect the angle jerk to be brisk. Here the angle jerk is diminished on the right side. So that is odd, correct. Okay, so what do you want? So what is the localization now?
Could be multiple.
Could be multiple levels.
Yeah.
Multiple level. So one high cervical cord, another one
Cervical plus lumbar.
cervical lumbar radiculopathy. Right side radiculopathy, that distribution says to your radiculopathy. Could be. Nobody can say no because as told before, somebody in the hip abduction, here the hip abduction extra is normal. Maybe distal muscle may be more affected than. Okay, let us see the process. Now, what do you want me to do?
So one doubt, how to localize the posterior column, sir? The vibration is patchy, antecervical spine is involved, and the lower limb sits.
Right. This is well-known pattern in cervical myelopathy, where the sensory will be maximum affected first in the upper limb, that too first in the little finger. Then only subsequent part will get affected. This time and again, we have been pointed out in my discussion. In high cervical myelopathy, start from medially to laterally it affects. Subsequently, all hand may be affected. And in fact, in more number of patients, upper limbs alone may be affected before lower limb get affected. Only in 20%, the lower limb get affected first in high cervical myelopathy. This is applicable to high cervical myelopathies, where the upper limbs are first affected. Pardon?
Antecervical spine is present, no, sir, but lower limbs it's impaired. Opposite.
What did he say?
Impairment of the vibrations. Antecervical spine is
decreased. Impaired.
Not impaired. He said normal, sir.
That is what he said is correct. So how do you explain that thing?
Again, multiple level.
No, need not be multiple level. It all depends upon which tract is affected first. See, it's a tractus cuneatus and gracilis. Gracilis is affecting from the lower, supplying the lower limb. Remember, these two, the two tracts are affected, depending upon which tract is more compressed. And usually, high cervical cord, the tract which compressed or involved is the cuneatus tract. That is where the upper limb get involved first in high cervical myelopathies. So it get affected, then it comes the upper part, the antecervical will be affected before the distal part get involved. Here, distal part is also affected. This vibration is embed both toes. Only the in between it is decreased. That kind of a patchy involvement is well. Various type of patchiness can occur in high cervical cord. Sometimes you can have high cervical can produce syringomyelic type of sensory loss for the pain. You can involvement in the upper limb may be involved, sparing in between. Then below that umbilicus sensory loss can occur. That pattern also described in high cervical cord. Part of it may be related to the compression producing ischemia also. It may not you can't think of that it's exactly due to compression alone.
So the left lower limb, what is the finding, sir? Left lower limb?
Normal. The power is normal. Impaired joint sense and vibration over the both toes. The right lower limb weakness already mentioned. Again, that vibration joint sense impaired on the right toe, right foot.
But the
So sensation over the right knee, sir.
That was normal.
Vibration sensation, sir.
Vibration was, he said, normal or the both knee. Vibration anti-nucleus.
Then anterior iliac spine it was decreased. No?
Yeah, that what is, you are perfectly right. That is the thing. So that's what I'm trying to say. That sometimes the sensory loss may be quite patchy. Okay, with the tractus unit is affected first, then you get upper limb will be affected first. Then I'm going to affect that the anterior superior will be affected. Then depending upon the compression where it is affected, maybe first starting in the lower limb.
Okay, sir.
Sir, he has got a pyramidal more on the right side, but the abdominal reflex is better elicited on the right side.
Correct. Again, tell you that it's not a strictly patchy involvement.
Yeah.
Or something else is occupying. Something else is causing some problem. Okay. So what do you want me to do? I'll explain everything later. Okay, MRI of the cervical spine. Okay. I'll go back to the cervical spine now. This is the brain was done because it has already came with the brain MRI. That is normal. Now this is cervical spine. Sagittal cut. Dorsal spinal cord. This is axial, the thoracic axial. Thoracic. This is the cervical T1. Cervical T2. This is the cervical. It's available only from C3 down. The first cut is C1, C2. C2 shows some hyperintensity in the cord. This is the picture they brought with the patient. This is probably at C1, C2 level. You can find out that this is the cord. You can find this cord is compressed by this hypointense lesion there. Maybe some osteophyte there compressing it. Again, you can find out the compression there. Again, you can make out the compression here. This is the cord. Okay, what is the diagnosis now? High cervical compression. You can clearly see the cord compression there, in the upper part, right? Then hyperintensity in the cord. It is kinked. And you can find out that also the axial cut compression also very clear. See, this is the compression. This is a C2 vertebral level, axis level. That's a compression here. The cord is compressed more on the, this is left side. You can find the compression is more on the left side. That is the abdominal reflex also decreased on the left side. Plantar is definitely ongoing on the left side, definitely. So what else you want to do now?
CT is fine. CT is fine to look for atlantoaxial dislocation.
Yeah. So that should be done. Okay, perfectly right. CT might be done. But some more.
Lumbar
MRI.
Yeah.
Lumbar MRI was done, no? It is not shown here. No, this
Not
is the
shown, only dorsal was.
Okay. Dorsal was there only. Okay. Lumbar is there. There's a lumbar. No, these are all brought with the patient. I did not do any MRI. Okay, now what will you do now? So are you happy with that I sent the patient to neurosurgeon? You're all not very happy. I'm also not happy. So why I'm not happy? This is the point. Not
More
contrast.
motor.
No, this is the point which Feroz has pointed out. See, if with the pyramid, he has got a compression on the left side. Okay. Absent angle check on the left side. But, absent abdominal reflex on the left side. But weakness only on the right foot. And how do you explain that right foot? And right angle check is decreased compared to the left side. And that plantar is wavering, not very definite. Left is clearly upgoing. See, if it had been a pyramidal lesion more on the left side, you expect that weakness due to the pyramidal lesion, expect that weakness, the reflex action to be brisk on that side, correct? The pyramidal lesion is more on the left side, that limb should be more weak. But here the right lower limb is weak. Is it not odd?
Yes, sir.
Correct? It's definitely odd. Okay. So something else is there in this patient. Okay. Then how do you explain the isolated weak right dorsiflex revert as the decreased angle check? And that too not fitting with the root pattern also. So what other test will you do now?
Now conductors.
Nerve conduction. Now look at the nerve conduction now. Decreased amplitude from the left peroneal and right peroneal. The velocity is decreased. Okay, that you don't ignore about the velocity because it should be less than 30 or borderline. It is decreased. Velocity is also decreased. But 2, and look at the right peroneal. The proximal conduction is proximal amplitude also decreased. That means it's got a clear element lesion affecting the tibialis anterior and the peroneal muscles. Not only right, left is also affected to some extent. And the velocity is borderline decreased. And the upper limb, again normal, except for the velocity, you can ignore that thing. And then left to the sensory potentials. Right swirly is decreased. Where the limb is also affected. Okay. Right superficial peroneal also compared to the left, which is 9.7 on the left side. Sorry, left side, right side, affected side is 5. Left swirl is 14.4, right is 6.4. The right side sensory also is affected. That means lesion is not in the root. It has to be in the nerve. Otherwise, snap will not be affected, no? So what else will you do? F5 latencies. I look at the F5 latency. Even in the unaffected upper limbs, the F5 latency is prolonged. There was no motor weakness in the upper limb, but F5 latency is prolonged. And obviously in the lower limb, both peroneal also, in the peroneal is also the conduction. Not only the affected side, left side also is prolonged. So what is he having now?
Radicular neuropathy.
CIDP.
Okay, here not you don't say radical neuropathy. You can see he's got a neuropathy. He's got a demyelinating neuropathy is present. Maybe demyelinating radical neuropathy. What is it is perfectly correct. So it is not simple high cervical cord compression. Okay, his numbness of the upper limb, everything could have been. He has got numbness for long. Now he has come with a foot drop. That is present complaint he has come. That is due to demyelinating neuropathy. That is not due to the high cervical cord compression. You got the point? Tricky case now. Very tricky case. So what will you do now in this patient? To do surgery first or treat the demyelination first? You can think for it, but more sinister thing is always demyelination, you can wait, no problem. There's no harm in waiting for 2-3 weeks of treatment to do, but for cervical cord, you cannot wait because it will make progress. So superadded demyelinating neuropathy. So what will you do? That's earlier the decision whether to do which one treat first is up to you. But the other one is a long-standing disease. You have to put the patient on steroid and things like that. And you have to continue for a long period of time. And by that, if you do surgery on that, the risk of surgery will be a little more high. So tackle the cervical cord compression first and then go for the treatment of the neuropathy part. In fact, some more tests has been done in this patient, CSF protein, everything has been done before giving treatment. But the point I brought the patient is that when you examine the patient, if some of the findings that out is not fitting with your thinking. Or when you talk in Malayalam, if you bite into a stone when you take your rice, that is something odd. Then always keep open mind. There is something odd. It is not going in a straight fashion. And most of the neurological diseases behave like that. Something odd thing will be there. When you find that odd thing, follow that. You have to don't take it straightforward. Don't ignore that. You have to chase that odd finding. Okay. Any questions in this case? Now, can you answer all these findings in this patient? Why abdominal flesh is absent on the decrease on the left side? Terminal train is more evident on the left side. Right planar is not upgoing because there is a superadded element finding there. That's when right knee angle jack has become decreased. Okay. Any questions?
Patient was operated, sir?
ഇല്ല ഞാനത് സർജറിക്ക് റെഫർ ചെയ്തു പിന്നെ I did not get the follow up. He must have ചിന്തിച്ചിട്ട് വരാൻ പറഞ്ഞു. He did not come for follow up. I saw the patient about 2-3 weeks back. I referred to the neurosurgeon. He may come after the surgery. So that they'll go and consider other people whether surgery is required or not. Then so many opinion will come. Then only you'll come back later on. Shall I go for one more case or stop here?
One more case, sir.
One more, sir.
Okay. The story of a 43-year-old female. History of aching pain on the right side of the neck for the last 5-6 years. Pain was more after work. It's a short case. No root pain. Noticed pain and numbness of the whole of the right palm 8 months back. And aching pain in the right arm and numbness of the right palm. And surgery was done in the wrist, with which the pain in the right arm and numbness subsided, but continues to complain and numbness of the right little finger. This is her story. So this examination, look at the examination very carefully. Or was all normal.
Note. ഇത് പൊക്കിക്ക ഇതും പൊക്കിക്ക ഇതും പൊക്കി പിടിച്ചോ ഇതും പിടിച്ചോ
Power was normal.
വെള്ളം മടക്കിക്ക വിട്ട മടക്കിപ്പിടി മടക്കിപ്പിടി
Long finger flex is normal.
ഇങ്ങോട്ട് തള്ളു എന്റെ വെള്ളോട്ട് തള്ളു
Normal finger abductors.
തള്ള
That's also normal.
തള്ളിക്ക വെള്ളം മടക്കിക്ക എല്ലാ വെള്ളം മടക്കി നൂർത്തെ
This Bowman sign was negative. The palmar interosseous also appeared normal. In fact, she had no weakness. Sensory you find is equal on both sides. He said it decreased on the right index finger.
ഇതും തമ്മില
It's normal. He said little finger is normal.
ഓപ്പറേഷൻ കഴിഞ്ഞ് അടിക്കുന്ന കാണേ
Then reflexes are all normally elicited. Triceps and finger flexion is almost absent. Maybe because of obesity, I don't know. Knee also is decreased. Angle is also decreased. Plantar is down going.
പ്രശ്നം ഇപ്പൊ രണ്ട് കൈ മൊത്തം numbness.
This is what he's telling.
ഇവിടുത്തെ numbness കുറച്ച് ഇവിടുത്തെ numbness കുറഞ്ഞില്ല.
So I just, because an examination is telling the numbness is on the, pain is decreased on the right index finger. But complaint was that numbness on the little finger. So I asked the history once again. Then she says again that initially the whole palm was numb. After surgery, everything improved except the numbness of the little finger. That is what she's telling. But objective examination shows decreased numbness on the right index finger. So an examination, painless, normal, no weakness of any muscles, sensation, decreased sensation of the right index finger compared to the left. DTR biceps supinator 1+, triceps, knee check, and ankle check diminished. So what is the diagnosis? Or what test do you want? Or just leave it alone like that? Only thing will improve with time? Or do you want to do any test?
Nerve conduction to rule out ulnar neuropathy, sir.
Right, very good. Perfect. So this is nerve conduction. See, look at the nerve conduction. This is done from outside. This is median right, left and right. First is left, the other is right. So right median amplitude is 7.23 on the right side. If you look at the ulnar is normal bilaterally. See, on the right side, median potential is less compared to on the left side, it is 17. Here it is 7 on the right side from the APB. So that means the ulnar CMAP is decreased. The ulnar CMAP is same, 11 and 12. That is motor part not affected in the ulnar. Let us see the sensory. Now to the sensory, left sensory is 28.2, right is 9.5. Again, right ulnar. But ulnar sensory is normal. Let me see. Left is decreased. Right is normal snap. The snap is normal in the ulnar distribution. CMAP is also normal in the ulnar distribution. But sensory and motor is decreased in the right median distribution, confirming our initial diagnosis of carpal tunnel syndrome. Then in a digit for comparison, I think it is that's what NCA study for the carpal tunnel. So FAV latency is normal. So what do you want me to do?
MRI, sir, cervical spine.
What do you want MRI for?
Syringe or something?
Sensory symptoms are present.
Syringe.
Okay. Syringe. But if before doing MRI, there must be some justification. No, just say patient telling numbness. Do you want to do that? Some objectivity is not there. Objective finding is not there.
Sir,
Okay.
right side finger flexion was brisk, no, sir?
No. Finger flexion is all just not absent. See, biceps supinator normal. Finger flexion is absent. Knee and ankle jacks are almost absent. She's an obese lady, so it cannot be. It may be normal for the patient. Okay. You want MRI cervical spine?
Yes, sir.
Yes, sir.
Okay. I'll give you MRI cervical spine. This is MRI cervical spine. Okay. Look at a compression at 3, 4, 5, and 6 compressing producing myeloma hyperintensity within the cord. Right? This is axial cord. You can see the significant compression of the cord anteriorly. Look at the lower panel now. See the cord. No, question that not. What made you do the MRI in the cervical spine?
History, sir, root pain and persistent numbness.
No, it's not a root pain. Initial aching right arm, which subsided after surgery.
The
It's not
numbness was the whole of the upper
Started in
limb.
the neck pain,
It was
sir.
like the whole upper
No,
limb.
he had hold of the upper limb and aching. That's common in carpal tunnel syndrome. Many carpal tunnel syndrome will come with numbness and aching pain. The surgery was done, that pain will subside. And after surgery, pain, everything subsided. She has no complaint. Only came that she was numbness with the little finger. How can I give importance for that? No weakness. Objectively, touch says everything is normal. Vibration normal, Johnson is normal. Sorry, vibration pain is normal, touch is normal.
The numbness of little finger is odd, no?
That is all correct. But female patients, many of them may over exaggerate. So, what test will you do? That's my question. What made me do that? See, look at this now. Joint position sense. That is normal on the right. Now let's select the right side, affected side. Impaired. One mistake. Again made mistake. See, she has got impaired joint positions in the right little finger alone, where she complained of numbness. Now, what is this point? The point which I told earlier. The first affected area of sensory loss may be in the high cervical cord, or cervical myelopathy may be only in the little finger. Now, just now, the last case I was telling you this particular point. So, unless and until you do the joint positions little finger, you will miss a high cervical cord compression. If somebody complains of paresthesia, the medial to the ulnar distribution, so-called ulnar distribution, middle part, always rule out high cervical myelopathy. Even before any other signs comes, the compression may be only in the posterior column. They may be inborn, the area effect may be only in the little finger. All of the fingers may be spared. Now, what is the result? Correct. This sensory complaint in the little finger is significant. But you have to corroborate whether you need to go for, whether you need to document the objectivity, look for the JPA sensation. Touch and everything will be normal. Just like this girl, you only examine the touch, is normal on the little finger. But she complains the numbness on the little finger. But that is numbness due to the impairment of the posterior column. 7% sense. Okay. So, any other questions?
She has two lesions, no, sir? Carpal tunnel and myelopathy.
Exactly. And the myelopathy is very mild, implicated in the posterior column. We need not do surgery in this, but just wait and see the cervical collar and avoid it. Let's follow up the patient and say, there's no motor weakness, no spasticity, nothing. But she has got an early compression of the cervical cord.
There is significant signal change, but sir.
A signal change is there, but that does not, see, whatever be the signal change, I think we go more clinically. See, I have seen persons with a cord like a thin threadbare cord with normal function due to the high Atlantic dislocation. Maybe cord is so thin to the point of a thread. Some things which we can't explain, long-standing condition. So ideally, if you send the patient to neurosurgeon, he will operate. And you should, and after operating, suppose his disability is going to be more, again, be problematic. Let us see how he is doing about this thing, and let us see how he's worsening. Definitely go for that. And in cervical compressive myelopathy, signal changes previously to say it's nothing, no myelomalacia, nothing. That edema all can subside with just cervical cord immobilization after some time. They revert back to normal. Okay.
Sir, is this predominantly carpal tunnel or radiculopathy, sir?
But predominantly carpal tunnel. Because that is the main complaint she had, all subsided, pain subsided, numbness of the whole of the finger subsided, except for the little finger. She had both the things together initially, but see, many people with carpal tunnel, they complain numbness of the whole palm, which you all hear every day in your practice. But his story here is everything subsided, but little finger alone did not subside. That is an odd point. If she had said, so my index finger number did not subside, I would not given importance to that. Okay. Shall I stop? Any questions before?
Thank you,
Okay.
sir.
Thank you,
sir.
Good night.
Night.
Thank you, sir.
Good night. Thank you, sir.
Good night.
Thank you. Thank you. Thank you. Thank you.
Thank you.
Thank you. Good night. See you next day.